One second.
Start. Uh, Good morning, students. In fact, this lecture on wound has been taken number of times, but there is always a confusion because the common topic is so common that we forget that we have to present them in a very systematic format because wounds are of so many types and classifying them and giving them proper management is the key. In fact, wounds and ulcers are same. When you talk of wound, what we talk about is different questions we are likely to get from wounds. Last so many years, every time you get a question on wounds. And what are they like? Usually, they are just like what you call it as a classify wounds, stages of wound healing, factors affecting the wound healing, and describe in detail the process of wound healing and factors. So, questions are kept in different forms. Similarly, in short notes, you always get around what is called as a hypertrophic scar and keloid. Very common conditions, and there is a basic confusion existing amongst how to classify hypertrophic scar and keloid. Healing of the wound delayed, what management has to be done? That is grafting. Different types of graft. So it is a vast topic, and we'll go in short about everything in details about wounds. So, coming to the wounds proper, you have to define it. What is the definition? Wound is a break in the integrity of the skin. Remember the word integrity of the skin or tissues, which may be or may not be associated with the disruption of the structure and function. So, it is a break in integrity. Whenever you call of ulcer, we talk of disruption or break in the continuity of any lining. That means ulcer is a continuity which is broken. That continuity may be in the skin or mucous membrane. So that means ulcer also is one type of wound. So what about integrity? It is integrity of the skin as well as the deeper structure. Integrity of a deeper structure may not affect the skin. So, wound is simply a disruption of any tissue. Any tissue disruption, that tissue may be soft tissue or it may be bone or any internal organ. Wound can occur to internal organs also. Ulcer also can cause into the internal lining. So, ulcer is on the skin or on the mucous membrane, whereas wound is on any tissue, be it a soft tissue, let it be bone or any internal organ. So that you must clearly understand the definition of wound. Now what comes is the classification. So many classifications. But remember, every classification has got a certain meaning. Why do you classify wound? Because you want to plan the management of that wound. That is why you classify. In classification, indirectly, the character of the wound, the infection of the wound, and the management of wound, everything comes in classification. So there are so many classifications, and commonest among them is what is called as a rank and Wakefield classification. This is the simplest one. What it says? Any wound, any wound, whether it is a tidy wound, that means it is a clean wound, and opposed to that, untidy wound. So this is not a surgical wound. Tidy wound means these wounds are caused because of surgical incisions or usually because of sharp objects. These are clean incised wounds, and more important, these are healthy wounds without any tissue loss. Understand? By meaning tidy, we say that they are clean wounds and they don't have any tissue loss, which is very important. The moment tissue loss comes, the treatment or the management changes. So what is happening in tidy wound? The treatment is very simple. It is primary suturing. And so what? Healing here is going to be by primary intention. We'll consider these intentions afterwards. As against that, we come across untidy wounds. And what are the untidy wounds? They are due to different causes. Tidy wounds because of a clean cut incision. Untidy wound because of different types of factors. Like what? Either by crush injury, tearing forces, avulsion of the skin during bike accident, devitalizing injuries because of pressure, the things can get devitalized. Vascular injuries, remember they are the deeper structures, complex wounds, multiple irregular wounds, and commonest untidy wounds are burn wounds. So there is a table which is clearly showing what is it? Tidy versus untidy wounds. Tidy wounds are incised, clean, healthy, without a tissue loss. Against that, untidy, crushed or avulsed, contaminated, devitalization of tissue and associated tissue loss. So that is why you have to differentiate between tidy and untidy wounds. Now another classification coming forward is different types of based on the type of wound. What is the intention of the wound? So what is primary wound? First is clean incised wound. This is a linear wound which has got a clear edges. Edges are important here. Against clean, it comes lacerated wounds. What it means? The edges are ragged and element of devitalization. So treatment is differing now. Here treatment is wound excision and primary suturing. Don't lacerate it. In clean wound, it is simply suturing. The third type is by simple pressure, bruising and contusion. This is one of the type of wound. What is happening here? There is a discoloration because of hematoma, but there is no skin break. In bruise, there is no skin break, but it is also type of wound. Contused lacerated wound. That is a common finding. CLW. That means there is contusion as well as wound is lacerated. That means the periphery of the wound is more. Next comes commonest hematoma. Again in hematoma, the skin is not broken. So these are all different classification. Closed blunt injury. Nothing can be seen from outside, but there is an injury deeper one. Punctured wounds. Small sharp object can give punctured wounds and also bites. Human bites are most toxic, remember, because organisms of the mouth directly enter into skin where it is a foreign flora. So human bite is taken as a grievous injury in medical legal cases. Then comes abrasion, traction and avulsion. That means the muscle is pulled from its insertion or origin. Next is crush injury and penetrating stab wound. So these are according to the type of wound. That means which structure has caused the wound. So this is few pictures where they are showing types of wound. In first, it is a tidy wound. In next, it is untidy wound. What is happening here? Lot of skin loss has occurred. The last picture shows CLW. That means contused and lacerated wound. This classification is for the management purpose. The most important structure for us is classification, which is based on the thickness of the wound. Thickness is the primary thing which is going to differ into the management. According to thickness, what are it? First is superficial wound. Why do you call it superficial? Because only epidermis and dermal papillae, that means which is outside of the dermis, are involved. So what? These are going to have a normal healing. Next to superficial, it is a partial thickness, slightly better. What do you mean by partial thickness? There is a skin loss up to deep dermis. What is deep dermis? Only deepest part where hair follicles and sweat glands are not disturbed. That is also important because these things are going to give healing of the wound without a skin graft. In partial thickness, healing occurs by secondary intention. Third is full thickness. Here it is more bad. Here entire skin and subcutaneous tissue are lost and there are spacing out of skin edges. Skin edges are wide apart. So it is a full thickness wound. Superficial, partial thickness, full thickness, then comes the deep wounds. By depth means wounds are going deeper into muscle or maybe more deeper structures. On the type, again it is a complicated wound. That means what complication? The wound is involving some major structure like a vessel or nearby nerve. That makes it complicated. The last one is penetrating. What is happening? This penetration may look very superficial on the skin, but it can enter into a natural cavity like peritoneum, chest, or it can damage an organ. So this classification on the thickness and depth of the wound. Okay. Now we are coming to what we are routinely dealing is with the classification of surgical wounds. Surgical wound also has got a potential danger of getting infected. In classification of surgical wound, first comes a clean wound. What is this wound? Surgical wound is the one which is given by a surgeon to the patient. So you should be very clear in understanding how much is the risk of infection. Remember, all this management we are trying to do. The end result is prevention of SSI, prevention of a local infection. What do you mean by SSI? Surgical site infection. So that is our basic purpose. So clean wound means a planned surgery. Like you are going to excise the lipoma, you are going to excise the fibroadenoma, even hernia, or you can call heart transplant also. They are clean wounds. The moment you say clean wounds, we don't expect infection rate more than 2%. Against that, clean contaminated wound, there is an already element of infection. Like what? In a case of appendicectomy. In case of cholecystitis. The moment you call it appendicitis, cholecystitis, there has to be infection. So you are already operating over an infected part. That makes the wound clean but contaminated wound. So what is the effect? The likely infection rate is approximately 10%. All our attempt should be to minimize it. Then comes contaminated wounds. These wounds are already contaminated. The pus or infective focus is already there. Like what? Acute abdominal conditions of a perforation peritonitis and roadside accidental injuries. Here the mud, dirt itself is causing contamination. So end result, the chances of infection are very high, more than 15 to 30%. Last comes where there is infection rate of 40 to 70%, very high infection rate. But you have to cure it and you have to operate. So what are these? When you are draining an abscess, a pyocele, empyema gallbladder and fecal peritonitis. Remember, whenever there is a fecal matter in the peritoneum, it is a dirty infected wound with a very high chances of infection. Again, you have to make all attempts to prevent that infection. So this is a diagram which is classically showing what are the types of wound. First comes clean contaminated, infection rate preferably less than 2%. Clean contaminated, 30% infection. Infected wound, already infected, maybe 50%. And worst are uncontaminated, unclean wounds. So, acute cholecystitis where already it has ruptured. The bowel obstruction where there is a spillage of fecal matter. These are the unclean contaminated wounds where there is always a chance of infection and you have to be prepared for the infection and prevent the septicemia. Understand? So this diagram is more simple. You remember this one, you will remember all the classification. There are 4 classifications in the simple diagram. What is it? Simple wounds. Simple means only skin involved. Complex, skin plus a major structure like vessel, nerves. Second is closed wounds. That means nothing has been opened. Skin is intact. What are they? Contusion, abrasion and hematoma. They are closed wounds. Practically they are uninfected. What is open wound? These are the incised wound where skin is involved. Lacerated wound, crush injuries and penetrating wounds. So this is closed and open wounds. Third classification, tidy wounds and untidy wounds. And fourth we have seen is mainly related to surgery. What is it? Clean wound, clean contaminated wound and dirty wound. So these are the 4 wound classifications. The moment they ask wound classification, you must write all these classifications. Here, Rake and Wakefield classification. So you should never forget that. Next comes, the wound has occurred. What next? So what is the ATA pathology of a wound healing process? Every wound has to heal. One cannot have a healed lifelong. They are called as non-healing wounds. At present, we are talking of healing wounds. So, what is wound healing? This wound healing is a complex method, and what are you trying to achieve? Is anatomical and functional integrity of all the disrupted tissues, not 1 or 2. Ultimate aim is making it a pre-operative stage. So, wound healing process is a complex process where you want to achieve the pre-operative, that means previous level. So ultimately what is it? What are the types of wound healing? How do the wounds heal? Everything has a definite pattern. The wound healing goes into 3 phases. First is what we intend is a first intention. First intention means every surgeon, every doctor wants to heal the wound primarily. What do we mean by primary? It occurs in a clean incised wound or a clean surgical wound. What we do here? Wound edges are approximated with suture. That means there is a primary epithelial regeneration and there is less fibrosis. All attempts are to reduce the fibrosis and epithelial regeneration. Here, the wound will rapidly heal. There will be complete closure. That means there is no false track behind. No hematoma, no foreign bodies left there. It is a primary first intention. So how does the scar look? It will be linear, smooth and supple scar. This word is important. If scar is painless, supple, patient doesn't realize that there is a scar. It is a supple scar. What next? Second intention. First intention probably we are not able. So then comes the second intention of a doctor. What is it called as? Secondary healing. Where it occurs? Wherever there is an extensive tissue loss. If there is tissue loss, we have nothing in our hand. Then also we have to make it heal. And it occurs into major trauma, burns, and wound where there is a sepsis. By sepsis, you mean infection. What is the change in secondary healing? Secondary healing is not by epithelialization, but it is by fibrosis. What it will do? Fibrosis will lead to wide scar, often what is called as hypertrophied and contracted scar. But this is going to lead to disability. First intention, no disability. Second intention, disability. And here repithelialization is occurring from different dermal elements or wound margin. So remember, all the wounds heal by wound margins. It is a very slow process. Okay, that is why you have to interfere. And third intention, where we are not interested, but that third intention is called as tertiary wound healing or a delayed primary closure. Sometimes this is intentional. What is intention? We have to close the wound, but when the wound becomes clean. So, after wound debridement and control of a local infection, we have to close the wound either with a suture material or a primary skin graft. So this is the delayed primary intention. So there is a healing by tertiary intention. Then comes your intention is clear. Your intention is good. But what actually is happening in the wound in healing? What are the process of wound healing? What is happening? How the wound healing occurs. This is most important for exam as well as understanding. So mnemonic is IESM. I stands for stage of inflammation. This stage of inflammation forms a granulation tissue and they are organized. There is a formation of collagen and ground substance. This is the first stage of inflammation. Second comes I. Then E means stage of epithelialization. Then comes S. What is S? Stage of scar formation and resorption. There are so many extra things are healing, but you have to remodel them. So resorption, what is extra? You have to reabsorb. Stage of scar formation. Last is stage of M, that is stage of maturation. So what are the stages of wound healing? IESM. Inflammation, epithelialization, scar formation and maturation. Understand? So what are the different phases? First phase is what is called as IPR. I stands for inflammation, P stands for proliferation and R stands for remodeling. So whatever you give, the body will remodel it according to its requirement. So first stage of what we call it as an inflammatory phase. You remember all this, they are going to be asked what are the phases. Inflammatory phase is either a lag phase or an exudative phase. It is starting pouring in of a number of substances which will take away the bad and start the healing. It lasts for how many days? This lasts for 4 to 6 days. Stage of inflammation. And what are the characteristics of inflammation are? Everybody knows rubor, calor, tumor, dolor and loss of function. Here the patient protects the wound so that inflammatory phase will start the healing. Next comes what? Proliferative phase, P. What is happening here? Collagen and fibroblast are getting embedded into the tissue. They give the strength. And what happens? This stage lasts from 7 days to 6 weeks. I 4 to 6 days, P 7 days to 6 weeks and R remodeling is 6 weeks to 2 years. Up to 2 years remodeling keeps on occurring till it takes a normal process. So in remodeling, there is a maturation of collagen. What collagen is giving? It is responsible for the tensile strength of the scar by cross-linking. And few MCQ questions, collagen production is not present after 42 days of wound healing. After that, collagen does not occur. Understand? That is how the whole process of a wound healing is progressing. Remember one thing, the strength of a wound will never be the same as it was previous. In spite of best attempts, always write down. The wound will heal by 70% of its previous strength. This is MCQ question. The strength of the wound is never attained in spite of best attempt by surgeon or whosoever or even nature. So, what are the factors? We have tried so much about factors of wound healing. So, what are the factors that are going to affect it? Remember, in any factor, there are two types. One stands as a modifiable factor, another is a non-modifiable factor. By modifiable, we mean we can change it. And non-modifiable, it is not under your control. That means either they are genetic, either they are idiopathic, or they are part of some syndrome. You cannot control it. So they are non-modifiable. So concentrate more on modifiable structures. So modifiable local factors. What are the local factors which are going to affect the wound healing in a bad part? Not helping, affecting. First and foremost comes is a infection. Infection is always imparts or delays wound healing. Presence of necrotic tissue or a foreign body. Foreign body will never allow wound to heal. The foreign body has to be removed. Third is ischemia. Poor blood supply will not allow wound to heal. Similarly, proper venous and lymph drainage has to be there. In trauma, there is venous edema, lymphatic edema, again hampering the wound healing. The tension in the tissue, hematoma, poor apposition of the wound layer, unfortunately recurrent trauma. Once trauma treated, again gets trauma at the same place, which is very common. It is a local factor. Sometimes the patient has received irradiation for some other purpose and all the wounds of irradiated area are having poor healing capacity. Next comes site, where the wounds are. The wounds normally over the joints and back, they have got a poor healing. So this is non-modifiable fracture. You cannot prevent it. Wound over the joint, how can you do it? You can give a rest to the joint. Diseases like osteomyelitis and malignancy. The type of wound which occurred, inside lacerated, crushed and avulsion, and tissue hypoxia. So local oxygen concentration, if less, the wound heal slowly. So these are the local factors. Now coming to general factors. Many of them are modifiable, many of them are non-modifiable. Age in children, wound healing is always very good. Over the age, old age, it becomes less prominent or more problem because associated atherosclerosis and turgidity of the skin. Other factor mainly responsible is smoking, malnutrition, vitamin deficiency like vitamin C, vitamin A, anemia. The patient with anemia has got a poor healing power. Then what? Malignancy, uremia, jaundice, diabetes. Diabetes itself is a great topic for wound healing. The diabetes, because of its associated nephropathy, doesn't allow wounds to heal for a very long time. Associated metabolic diseases. Nowadays, HIV and immunosuppressive diseases or immunosuppressive drugs. Even steroids and different types of neuropathies. Because there is a neuropathy, the wound is not going to heal, because with neuropathy there is less blood supply. So local factors, general factors. You must remember this by heart. Anytime you even if asked by asking you to the waking up in the night, you should tell the local and general factor. So what are the factors they are going to affect the wound healing? First, the site of the wound. Wounds over a surface area or flexures heal better than the extensors. What are the structures involved? What is the mechanism of injury? Contamination is there, whether local factors, associated systemic factors, and sometimes in a large area, the patient taking chemotherapy will have a lower resistance and less healing of the wound. So this is in nutshell the factors influencing healing of the wound. So this is diagram which shows how the wound is going to heal. So these are the stages. First and foremost page is I. I stand for inflammation. Vascularity is increasing. Then what is happening? Proliferation. Proliferation means everything is getting clubbed together. And last is maturation. Okay. So this is how the wound healing has started. So the wound healing, what is our role? For all purposes, wound healing is a natural process. We have nothing much to do that. Our aim is to give a healthy wound, non-colored wound and earlier wound. Non-infected wound is our purpose. Clean and cosmetically acceptable wound. So what are the stages of management of an acute wound? To start with, foremost important goes to cleansing. You have to clean the wound so that no debris is left over the wound. For that, you have to explore the wound and come to a specific diagnosis regarding the cause of the wound. Debridement, you have to repair the associated structures and you have to replace a lost tissue wherever there is indicated. Next comes, if you know this wound is not going to heal primarily, you may have to think of a skin cover. This is a part of management plan. Aim is skin closure without tension, because as long as there is a tension of the wound is not going to heal. That means the planning of all these elements has to be in your mind whenever you are going for wound healing. Remember, it has to be a careful tissue handling. Rough tissue handling will again delay the process of healing. So, careful tissue handling and technique should be absolutely clean and meticulous. No rushing, no dirt. Okay, this is the management. So, what are the classification of a wound closure? How do you classify? We already considered primary intention, secondary intention, tertiary intention. Primary intention, apposition, normal healing, minimum scar. Secondary intention, wound left open, healing by granulation and associated poor scar. So secondary intention should never be attempted. If sometimes it is inevitable, that is different. Our aim is tertiary intention. It is called as a delayed primary intention. That means we are deliberately delaying the wound closure so that wound is in a better way. You are approximating the wound in a late stage. So, management of wounds, simple. We have discussed everything. Wound inspection. Remember, wounds can be in the vital area. It is not the primary wound management. If they are in vital area, you have to take care of associated pathologies. Because if you have a punctured wound over the chest, you have to bother for so many things. If the punctured wound is puncturing some vessel, you have to take care of the vessel. That means care in the vital area is more important rather than closing the wound. You have to take care of the associated fractures. They carry a primary importance. And skin closure comes afterwards. In the lacerated wound, you have to excise a bad part and then go for primary. It is a devitalized wound. Wait for the edema to subside. So any suturing of a wound with edema and tension is not going to heal. So better wait for delayed primary suturing or what is called as a tertiary intention. Okay. So deep divertless wound, wait. If it is small, go for secondary suturing. Vascular must be repaired. Nerves must be repaired. We are using lot of good material like polypropylene, that is Prolene 6070 for nerves. That means you have to take care of associated all parts. So what are the principles of wound suturing? First, primary suturing should not be done if there is an edema. So these are the basic principles. If they ask principles, you must write down this. Always associated injuries take a preponderance over the closure. It is a life-threatening injury. We should get preponderance or importance over the closure of the wound. Wound can be kept open. So it is called as proper exploration. So if required, you can extend the wound. If you are unable to see inside, extend the wound mainly for major nerves and evaluation has to be done. After that, it is a proper cleaning, all the procedure of asepsis, SOS, excision of the wound and debridement, removal of foreign body, skin closure if possible, only without tension. If not, skin covered by flap. Here, flap can be immediate or delayed. In extremity injuries, if it is superficial injury with dermis, primary skin grafting is always preferred. This saves lot of time, it saves lot of infection, lot of cost also. All the anti-itch wounds should be made tidy and clean before suturing. Aseptic precautions, antibiotics, and you have to inspect the wound. It is not that once you have sutured and things are over. You have to keep a proper watch over them and suture removal as per the period required depending on the area which is sutured. They differ. But ideally, many of the sutures can be removed after 7 days. That is a separate topic. So what you have to remember? It is a wound toilet. How do you do it? The toilet of the wound with normal saline, which is the most important ideal, sometimes adding betadine or adding hydrogen peroxide. So you have to clean the wound. You have to wash it thoroughly so that no organism or mud or dirt is left inside. You have to excise the wound wherever there is an associated devitalized tissue. Many times you have to do it once or maybe you have to do it serially. So what is happening in a roadside accident or in explosion? Lot of devitalized tissue has to be removed. How long you will remove it? Because devitalized tissue is not going to bleed. You have to devitalize as long as you are getting a free proper bleeding from the wound. There you can be very sure that this area is going to heal. The wound which is not bleeding is not going to go for primary union. Understand? So, what are the principles? By primary suturing, meaning suturing of the wound immediately within 6 hours. Primary suturing within 6 hours. Delayed primary suturing 48 hours to 10 days. And secondary suturing. Secondary suturing means after 10 days to 14 days. This is done in a all infected wound. After the infection is controlled, again you can try for wound closure when there is no edema. So primary suturing 6 hours, delayed 48 to 10 days, secondary 10 to 14 days. This is a basic you must remember. 6 hours, 48 hours and 10 days. 3 things. Now comes the most important problem with the wound healing, always asked in examination. 2 complications of any wound healing by nature. They are either type of scar they are getting, either it can be a hypertrophic scar or it can be what is called as keloid. So these two are major problems with wound healing. Both things our aim is to avoid. You cannot avoid hypertrophic scar in children, but all attempts must be made to avoid what is a keloid. So most important is from exam point of view and also understanding the process of wound healing is called as what are the differences between keloid and hypertrophic scar, because to start with both are same and their progression changes after 6 months. Causative factors are same but the general factors are totally different. So you remember this chart of differences between keloid and hypertrophic scar. You must remember this. What is it? The keloid has got a genetic predisposition. That means it is a familial tendency to develop keloid. It is a non-modifiable factor. Understand? Non-modifiable. You cannot stop keloid from growing. As against hypertrophic scar, no genetic predisposition. You can prevent hypertrophic scar by a proper treatment. Where do they occur? Keloid mainly over the chest wall, that is sternum, upper arm, neck and ear. Ear looks very bad, but unfortunately by ear piercing by a female in familial tendency genetic can grow into very bad keloid. As against that, hypertrophic scar can occur anywhere in the body, more common on the flexor surface. The growth of keloid is continuous. There is no time limit. And most important, even if it is a small incision or small wound, the keloid can extend to normal skin. Against that, in hypertrophic, usually they all stop growing by 6 months and they are limited to the scar tissue only. These keloid have a very poor response to the treatment. Whatever you do, they will have their own course. Against that, here the hypertrophic scar has had a good response to local corticosteroids. Keloid is more bad. Recurrence is very high. Against hypertrophic scar, no recurrence. The basic difference lies in the type of collagen. What is happening in keloid? This collagen is called as type 3 thick collagen. It is 20 times more thicker than a normal skin. And in hypertrophic, it is type 3 fine collagen. It is 6 times more thicker than the normal skin. Keloid has no relation to the size of wound. That means once they are given free hand, they will start growing on their own. As against hypertrophic is related to only size of the injury and the duration of healing. Keloid common in adolescent, common in female, whereas hypertrophic common in children and in both sexes. The keloid is more common in black people, that means African Negroes, in 15 times more. As against hypertrophic has got no racial predilection. The structure, thick collagen for the keloid, fine collagen for the hypertrophic scar. Vascular, tender and itching. Remember, this itching is very bad. In keloid, itching is one of the major complaint of patient. Against hypertrophic, there is no itching, non-tender. Keloid has got a progressive natural history. Hypertrophic, there is an element of regression. The problem for keloid is hyperesthesia, ulceration and itching. Hypertrophic scar, nothing. The patient with a large keloid does not even like to wear the clothes because that touch also causes hyperesthesia. So we are considering keloid now. If you want to write down a short note on keloid, we have considered the difference between keloid and hypertrophic scar. In keloid, as a short note, you must know common in blacks, genetic predilection, and it is very rare in Caucasians. What do you mean by Caucasians? The people living in the Caucasian hills, that means European. In European, keloid is rare. In this, it is a type 3 collagen. Here, keloid can grow after 6 months to many years. Brownish black occurs in unnoticed trauma. This is something funny. Many times, even a simple pinprick can give rise to very large keloid. And unnoticed trauma, it is called as a spontaneous keloid. This is more common in African countries. Site, common in sternum and extensor surface. Again, this hypertrophic scar occurs over the, where they occur? On the flexor surfaces. Now comes the management of hypertrophic scar and keloid. What are you going to do for that? The basic treatment here is nothing. There is no classical treatment for keloid. But for hypertrophic scar, you can give elastic garments. That means a pressure garment to prevent the growth of the tissues. Second is nowadays commonly used is a silicone gel. That silicone gel gives pressure over that. We don't know the mechanism. Steroid sometimes are helpful in keloid to prevent the symptom. But they are treatment of choice for hypertrophy. Excision, recurrence is common, but in keloid, excision immediately followed by irradiation is nowadays treatment of choice. Different types have come up. Intralesional excision, that means you are excising only the keloid, not the skin part of it. Because the moment you irritate the skin, again the keloid will regrow. Laser management, vitamin E, palm oil, everything is there, but none of them have proved to be satisfactory. So, this is regarding the keloid and hypertrophic scar. You must know this by heart. In general understanding, it is nice to know how we are going to classify wounds. These days, they called it as a two systems. First is Southampton system, another is Assessip system. This Southampton is a commonly followed wound grading system. What it is? Grade 1, grade 0, grade 1, grade 2, grade 3, grade 4. Grade 0 stands for normal healing. Southampton wound grading system, grade 0 stands for normal healing. 1 is mild bruise and erythema. So on inspection findings, 1A minimum bruise, 1B considerable bruise, 1C associated erythema. Grade 2 stands for erythema and signs of inflammation. Again ABC depending on the where the inflammation at one place at the suture line or around the wound. This is regarding erythema. Grade 3 stands for the discharge. Any discharge from a wound is bad. Any discharge for that matter. More bad is serosanguinous discharge because this is precursor of infection. In grade 3A, how many points are getting serosanguinous discharge? Even if you have sutured wound, at one point, all the length and large volume. More the volume, more is the risk of infections. Grading and prolonged. That means the wound is giving discharge for more than 3 days. So this is grade 3. And in major complications, 4 is pus. Infected wound in Southampton system is grade 4. 4A, 1 point, more than 2 centimeter. 4B, along the wound, goes to more than 2 centimeter. First is less than 2 centimeter. And grade 5 stand for deep and severe wound infection with a hematoma where aspiration is required. So, try to remember the Southampton system of a grading of the wound. Another is asepsis. It is just remember that. But Southampton is commonly followed. Next is, we'll just finish fast. You also must know what is it. It is called as a healing of the wound. What is most important is graft. G-R-A-F-T, graft. Graft is one of the way of making the wound heal. What is the graft means? It is a transfer of tissue from one area to other without blood and nerve supply. This is a simple graft we are talking. In pedicle graft, we are taking the blood supply. So, in simple graft, commonest we perform is autograft. What it is? It is a tissue transferred from one location to another location in the same patient. That means what we are commonly doing in our general surgery is a autograft. What do you mean by isograft? It is a tissue transfer between two genetically identical individuals. That means identical twins. This is a rare condition, but it has to be mentioned. Iso means isometric twins. Commoner than that is allograft, also called as homograft. Why homograft? This is from a human to human. They may be genetically different, but there are certain studies done, and from human to human, all transplantation done today are homograft or allograft, like kidney transplantation or like heart transplantation or liver transplantation, very commonly done now. Then comes xenograft. Xenograft is not technically allowed now. It is a transfer from one species to another species. So, skin grafting is a transfer of skin from one area called as a donor area to the required defective area. It is a recipient area. So, this is regarding the graft. What are the types of graft? Partial thickness grafts are very common. They are called as a split thickness skin graft, SSG. They are also called as Thias graft, where what are you removing? Full epidermis and parts of dermis from donor area. Remember, we are not taking hair follicles. That is why grafted area does not grow hairs. This can be thin or it can be thick. So, but major problem is they cannot be kept over the bone or tendon or cartilage. So, indications for a isograft or homograft is well granulated ulcer, clean wound, many times after malignancy, large area, many times after a breast removal, mastectomy, wide axis squamous cell area, and graft can survive over the periosteum if it is a full thickness graft. So we require what we require? Healthy granulation tissue or a primary grafting. But the load of hemolytic streptococci should be less. Technique usually removed by what is called as a Humbe's knife. There are different blades called as Down's blade. Different instrument used to cover the skin graft, Watson, and nowadays we are using power dermatome. So donor area is dressed and removed after 10 days. Recipient area first graft, scrapped and graft placed, and they have to be dressed separately. So what are the stages of graft intake? Remember, they are first is a stage of plasmatic inhibition where uniform layer forms between the graft and the recipient area. In stage of inoculation, the linking of host and graft which is temporary. Then comes the neovascularization. That means the new vessels start from the recipient area into the skin graft. So this is how the stage. Plasmatic inhibition, stage of inoculation and stage of neovascularization. Just I will inform the graft if excess stored at 4 degrees for up to 21 days. Disadvantages, there is a contracture of the graft, there is loss of hair, there are no sensations. There are no sensations in the graft. It is a dry scaling wound because there are no sebaceous glands. But advantage, it is technically easier, large area can be covered, and with the help of mesh, you can stretch the graft up to 6 times. So graft take is better, and donor area will heal on its own. Thank you. I am giving few questions for your MCQs. Just go through them and it will be interesting for you to find out how many answers you know. Thank you very much. Bye.